30 people, and I'm sure it'll quickly increase. So you ready to get going?
Yep, ready when you are.
Okay. So for everybody listening, this is the last session of our year. So we saved our best speaker for the final session of the year, a friend and colleague down at UC San Diego and clinical director of the hereditary angioedema. What's the last A stand for? The Angioedema Center down at the University of California. So a very interesting combination of events in our lives now. Talk on angioedema and COVID-19, Marc Riedl. So go ahead, Marc.
Great, thanks, Len, and good morning to everybody. Thanks to you all and Len for the invitation, and I'm honored to be bringing up the rear of your annual conferences. I understand you get a little bit of a break until September, but thanks for the invitation and for being here. So yeah, I'm going to talk about angioedema and COVID-19, and I'm going to bounce around a little bit. I realize that probably at some level everybody's a little sick of hearing about COVID, but there has been some interesting data and info that's come out of the pandemic with regard to what we see in clinical practice as angioedema. So I'll try to tie those two things together a little bit, and also in hopes that we're perhaps through the worst of it with regard to the COVID pandemic, but I have a feeling it's going to be around for a little while. So hopefully some of this will still be useful for your practice moving ahead. So here's my disclosures. I do quite a bit of work with a number of companies that are in the angioedema space. So just be aware of that as we go along here. And here's the objectives. So I'll talk a little bit about what we know with regard to angioedema symptoms associated with the SARS-CoV-2 infection. And as you all know, that's the virus, and COVID is the syndrome or the illness. I may use those interchangeably, so forgive me if I do that. It's just easier to say COVID sometimes. We'll talk about the pathophysiology of SARS-CoV-2 infection, and specifically, I'm going to drill down on the contact system, which, as you know, is the Calichron Boridokinin system, which is relevant to some of the angioedema conditions that we treat. We'll talk about COVID in HAE and what we know about that, and I'll touch on some of these targeted therapies that have been, of course, developed and FDA approved to treat HAE, but there has been considerable interest in those agents, whether they're helpful in severe COVID, because of what I'll talk about in the pathophysiology section. And then lastly, I'm going to wrap up, assuming we have a little time at the end. I want to bring you up to date on where we're at with diagnostics, because as you all know, one of our struggles when seeing angioedema patients, whether that's in the hospital or in the clinic, is what tests can we do that will tell us if this is a part of the allergy system, so-called histaminergic angioedema versus non-histaminergic or bradykinin-mediated conditions. And I probably don't have to tell you, we struggle in that realm because of the lack of diagnostics. So I'll give you a quick update on where that stands so that hopefully you can anticipate some future advances there. All right, so I'll start with this. This is very basic. You guys probably know all of this, but I always want to sort of set the stage so we're all speaking the same language. And of course, angioedema is localized swelling. It usually involves the skin or the mucous membrane, and importantly, it's non-pitting. I just saw a patient yesterday via video visit who has swelling, but it's pitting, and so that we're talking about the wrong thing if we're thinking about angioedema. It's a leak problem. That's what I tell patients. It's fluid extravasation into the deeper dermis or the subcutaneous tissues, and it's caused by really endothelial cell permeability, and there's various mechanisms for that. And of course, we know it can come on quickly. It usually develops over minutes to hours, and I'll say a few words about that in a moment. Asymmetrical most often, and typically has either itching or some pain associated with it, again, often depending on the mechanism. The duration is variable. It could last for a few hours up to several days, again, depending on the type. And we know that this is not something that shows up in just dependent areas. So, of course, lower extremity swelling can be angioedema if it involves a foot, but typically the sort of bilateral symmetrical swelling is not going to be something in our wheelhouse as angioedema specialists. Here's the broad differential, again, review for this audience, but of course we ask about allergen exposures, we ask about medications, including NSAIDs and contrast exposures, as well as antibiotics, which commonly can cause mast cell-mediated events. We know that there's the physical urticarias, and with those, angioedema comes along, often particularly with the pressure-induced type of urticaria and angioedema. And then there's chronic spontaneous urticaria, and we know that a large percentage of those patients are going to present often with concomitant angioedema symptoms. So those are things all familiar to us. And on the right is the mostly thought of as non-histaminergic or kinin-mediated. So ACE inhibitors, hereditary angioedema in its various forms. I'm not going to belabor that too much today, but be familiar with the types of HAE, both C1 inhibitor deficiency, and then this sort of expanding universe of mutations now that have been published and seem to be associated with HAE with normal C1 inhibitor. That's to say, familial angioedema conditions that do not respond to antihistamines and corticosteroids, and at least for most of these subtypes, have some response to the Boridokinin targeted drugs, even though we don't have rigorous studies in HAE with normal C1 inhibitor to know the best treatment. And then acquired C1 inhibitor deficiency, of course, is something we see once in a while. And lastly, idiopathic. And I'm sure you're familiar with the data. Like chronic urticaria, the majority of isolated angioedema is in fact idiopathic. It doesn't fit into any of these categories if you do all the extensive testing. And so we grapple with these idiopathic or spontaneous symptoms. We know from the data that most of that idiopathic angioedema is in fact histaminergic or mast cell mediated. So if you press hard enough on the allergy system, you will be able to prevent the recurrence in most patients. But there is a small group that have so-called idiopathic non-histaminergic angioedema. And this is just for those of you that see patients, this is sort of the approach that I use seeing, I spend most of my time actually seeing angioedema, and it's a little bit simplified, but it works most of the time, is to sort of think in this dichotomous fashion. Do I think it's a mast cell histaminergic problem, or does it sound more like a non-histaminergic or kinin-mediated condition? And these are the differences just by way of review. I talk a lot with our fellows and residents about the trajectory. The most effective tool we have with most of these patients is the history. And so listening very carefully to what's the onset of symptoms, how fast does it accelerate to its peak maximal intensity or severity, and then how long does it take to actually resolve? And there is some overlap, but for the most part, the mast cell mediated conditions are, as you would expect with allergic or sort of anaphylactic reactions, they come on quickly, they hit hard and fast, but usually within 24 to 48 hours, they've resolved or they've moved to some other location. In contrast, the kinin-mediated conditions like HAE, they're slower movers. There are rare exceptions, but for the most part, they take several hours to sort of reach a point where people are in trouble from the severity, and they often last for 3 to 5 days. So that trajectory is often a very good clue as to what the underlying mechanism may be. We all know that urticaria and itching are sort of hallmarks of mast cell mediated conditions, often with hives or urticaria. And then the response to treatment. That's the other piece that's really important to drill down on and listen to the patient in terms of what's worked for them. Most of the time they've seen other specialists or they've been to the emergency room or urgent care. So have those allergy treatments, which almost invariably patients will get because most of these conditions or symptoms are mast cell mediated. Has that had the expected or desired effect, either acutely or preventatively in terms of reducing the frequency and severity? So if it has, great, you're probably in that mast cell category and should continue to look for options there. if there's no response, then we have to think carefully about the possibility of HAE or some other kinin-mediated condition. And I just, again, highlighted some of those that are important to ask in the history. Okay, so let's jump into the sort of meat of the topic here, and that's angioedema and COVID-19. And I sort of divided this into a couple of categories. First, what we know. So what's been peer-reviewed and reported in the literature in terms of these conditions. And then I'll spend a little time on what's speculated. And this is sort of, hypotheses and theories based on some data that I'll show you. And I think we're still working out whether those theories hold up in the real world or sort of in the clinical realm where we're seeing patients. But it's some interesting things to think about. All right, so what do we know? There are, as you can imagine, published reports and case series now of angioedema as a symptom that's associated with COVID or SARS-CoV-2 infection. And this wouldn't surprise any of us. I think that I've been amazed at the laundry list of symptoms that have been associated with COVID now. It's pretty much anything and everything because of all the various ways that this infection affects the body. But angioedema is on that list, and these are cases that have been republished mostly in the adult literature, but there are a couple of pediatric cases that have been published as well. So I'm not going to go through these one by one, but I'll first show you there's actually the majority of these that have been published are so-called mast cell mediated or histaminergic. And we know that for a couple of reasons. One is, as you scan down this list, you can sort of see many of these have had hives associated with them. And so this isn't particularly surprising. We know that when we see people with hives, one of the questions we often ask is, have you been ill? Have you had an infection? We know that urticaria and mast cell mediated angioedema is one of the ways that, at least in some individuals, it's reactive. It sort of gets stirred up when there's a viral infection or other immunostimulatory event. So this isn't particularly surprising. Some of these also, if you dig into these and read, they were treated with antihistamines and corticosteroids, and they got better within several hours, as you would expect with a mast cell mediated event. So this is sort of the lion's share of what's been published. And so I will tell you, we've been called to the hospital a number of times over the last year and a half and to see these patients, and the majority of them have responded very well to the usual cocktail of allergy medicines that we treat urticaria and angioedema with. What's a little less common but interesting is these few publications. And these appear to be non-histaminergic or non-mast cell mediated angioedema reports. It starts here with this first publication. This is a group out of Buffalo, and you can see it was in the Blue Journal for Pulmonary and Critical Care. And these were four patients of African descent who were actually fairly far into their COVID course. They were in the ICU. They were quite ill. Most of them were intubated. And 2 to 3 weeks into their course, they developed these very profound upper airway, lip, tongue, facial swelling. And interestingly, at least according to the report, none of them responded to high-dose antihistamines, corticosteroids, and in fact, a couple of the patients ended up with tracheostomies because of the duration and the severity of their angioedema. So again, it's difficult to prove a bradykinin-mediated angioedema with laboratories. I'll touch on that at the end of the challenges there. But these do seem to have a course and a lack of response to usual treatment that would be consistent with a kinin-mediated angioedema. And then one publication in our literature from Annals, again, a patient that was fairly far into the course of the COVID illness and did not respond to antihistamines and corticosteroids. Interestingly, this group actually gave C1 inhibitor concentrate, and the patient got better within, I think it was 48 hours. So again, hard to prove that that's what turned things around, but that was part of their report. So we'll talk a little bit about, again, in a moment, about the role or the hypothesized role of some of these treatments targeted at Calichron bradykinin in these syndromes associated with COVID. And then the last one, you can see these case reports have now made it into the cardiology literature. This particular patient they report on here was a patient who was also on an ACE inhibitor. The other reports I mentioned were not. And so these authors sort of hypothesized that maybe there's a double hit here. There's the ACE inhibitor, which blocks the degradation of bradykinin, but also, as we'll talk about, the effects of the SARS-CoV-2 infection on the contact system, and perhaps people on ACE inhibitors, might show up with a greater risk of kinin-mediated angioedema. Let me be clear, that hasn't been proven, but that's sort of what this group speculates, and therefore this is of interest to a broader audience, critical care and cardiologists as well. Now, this is a diagram that is actually pulled. I adapted it from this case report. But I wanted to just share a phenomenon that we've seen. And if you look at these case reports, seems to hold true in the relatively small number of cases. But that's to say, this diagram here represents a mast cell mediated angioedema case report. So you can see the symptoms started about a little less than a week into the course of the infection. Again, there was treatment rendered and the patient got better within, at least with the angioedema, within a day or two. The hives took a little longer to respond. But the point here is that it was sort of very rapid onset and early in the course of the COVID illness. What we've seen, not just from the literature, but I'm sharing our anecdotal experience because we've seen a number of these patients in the hospital, is that the bradykinin or presumed bradykinin non-histaminergic symptoms seem to show up later. So these have generally been patients that have been in the hospital, often in the ICU for a protracted period of time. And most of the case reports show that these non-histaminergic symptoms that don't respond as well to antihistamines and corticosteroids show up somewhere around the second week of the illness and sometimes even into the third and fourth week. So I don't know what that means. I'm just sharing it with you because if you're called to see a patient like this, I think this is a pattern that's holding up in terms of what's in the literature and also what's been seen, that these later onset symptoms may be more likely to be non-histaminergic, and the early symptoms when the infection is first sort of taking hold, more likely to be histaminergic. So take it for what it's worth, but that's an interesting pattern that we sort of observed and again, is seen in the little bit of literature that's been published. All right, so let's turn now to the contact system, the Calichron bradykinin system. And this is a diagram I'm sure you've seen a number of times. It's very relevant, of course, for our understanding of hereditary angioedema. While it's not necessary to sort of memorize this unless you're taking the boards in the next couple of years, or it is important to recognize that the treatments that we have for HAE, of course, are all based on the understanding of this system. So A, nothing to do with allergy, and B, really focused on bradykinin as the mediator that causes the vascular leak that leads to the angioedema. And of course, here, if we're talking about HAE, it's the lack of C1 inhibitor, those pink dots in most patients, that lead to this dysregulation, namely factor 12 activation and Calichron activity, and you get this sort of snowball effect with excessive bradykinin leading to the vascular leak. So I tell you that not because we're really going to talk about HAE management, but there's been renewed interest in this pathway because of what's been seen in COVID-19 and all of particularly the severe pulmonary complications. So let me have a quick sip of water. All right, so I don't know if you guys were familiar with this study. This came out in July of 2020, so a few months into this terrible pandemic that hit the globe, and particularly the U.S. And I was aware of this because I immediately started to get phone calls from patients and other colleagues about, did you see this paper about bradykinin in COVID-19? So this was as you can see, a computational biology group who used this supercomputer at the Oak Ridge National Lab. And I know nothing about supercomputers, but I'm told that this is the second most powerful computer in the world. What they did is they had at this point a huge collection of BAL samples from people that had been in the hospital for severe COVID with pulmonary complications. And they took 17,000 of those BAL fluid samples and analyzed them for the expression of 40,000 genes. And they plugged all of this data into the supercomputer. And despite it being the second most powerful computer in the world, it took it about a week to crank out the analysis of this. And again, what they're looking for is the over or under expression of certain genes that might give us a clue as to why people were developing the severe pulmonary complications of COVID. So this was sort of, the beginning of, or the genesis of a lot of the interest in the contact system in COVID. And I won't pretend to know how to read this fancy diagram that they published, but what you see here is the overexpression and underexpression of certain genes. Now on the left is angiotensin receptor 1-like genes. These are actually genes that vasoconstrict and lead to elevated blood pressure, but basically are anti-leak, anti-vascular leak. And on the right is the AGTR receptor 2-like responses, which lead to vascular permeability. And so there's, of course, this balance or homeostasis between these normally. What they came out with from this crunching of the data from the supercomputer was a pattern of decreased expression of angiotensin converting enzyme, and with that increases or upregulation in angiotensin converting enzyme 2, renin, angiotensin, kininogen, calichron, and the B1 and B2 receptors. And we would recognize a number of those things, kininogen, calichron, B1, B2 receptors, as being very important for vascular leak, at least in the setting of what we understand for hereditary angioedema. So this was, again, sort of the genesis of some of the interest in the contact system. And interestingly, this group included as part of their paper the suggestion that some of these medications listed here might be helpful for preventing or treating the complications of COVID, particularly in the lung. So again, we're familiar with at least the top 4 lines here for things that we've been using for a number of years to treat hereditary angioedema based on their targeting of either calichron or the B2 receptor or multiple targets, as in the case of C1 inhibitor. So this was all sort of theorized, hypothesized, but it generated a lot of interest, and for better or worse, it generated additional papers. So some with these catchy titles about saboteurs here from in a pharmacology journal, again suggesting that we should be looking at these medicines that might help downregulate or the contact system. And then the one that really, again, I had patients calling from all over with this last article suggesting, or at least postulating, that HAE might be a major risk factor for severe COVID complications. And so we spent a lot of time telling people we don't know, which is the truth. There was a lot of theories and hypotheses, but we had zero data at this point to know whether this truly was going to be a problem with regard to COVID infection in our patients. So let me walk you through a little bit about what we know. And this is one of these diagrams that, of course, makes people glaze over because it's very complicated. But let me try to pull out what's been published and sort of what this looks like. And most of this is based on, of course, either in vitro or animal models. We don't know a lot about what's happening in humans even to this point. I'll show you a little bit of the clinical data that we have. But what we do know, on the right, SARS-CoV-2, the virus, we know that it gains access to cells through this ACE2 receptor. And what happens now, we know that when ACE2 is activated or hijacked by the virus, it actually results in downregulation of angiotensin converting enzymes. So this was a bit controversial at first. There was upregulation, downregulation, but it's pretty clear now. The preponderance of data is that through a variety of feedback mechanisms, one being the presence of angiotensin 2, that you actually get not only downregulation of ACE2 with the infection, but also downregulation of of ACE. And if you recall back to pathophysiology, ACE is, of course, one of the pathways that degrades bradykinin. So loss of ACE results in potentially excessive bradykinin, despite there being C1 inhibitor and the other enzymes. And that results, of course, in activation of the B2 receptor, which leads to inflammation, vasodilatation. The other thing that happens is that, of course, this is not happening in a vacuum. There's inflammation, and we know that with inflammation, you get upregulation of the B1 receptor. That's an inducible receptor that comes with inflammatory responses, whereas the B2 receptor is a constitutive. It's sort of always expressed. But at any rate, you get, with bradykinin, you get some degradation to des-Arg bradykinin, which is also an active mediator, primarily on the B1 receptor. And again, since you're lacking ACE2, you get excessive accumulation of not only bradykinin, but des-Arg bradykinin. So this is part of how this all fits together with the infection, the downregulation of these enzymes leading to excessive bradykinin and des-Arg bradykinin accumulation. Now, the other thing that's been postulated and not really proven yet with this specific virus, but has been seen over the years with other viruses, is the activation of the contact system directly by the virus itself. And so this has some, again, if you activate the contact system, again, you feed into bradykinin production, but also may play a role in some of the clotting issues, again, factor 12 activity leading to coagulation and clotting. So this really remains a bit of a hypothesis, but like I said, other viruses, this has been shown to be a direct activator of this system. If we sort of now zoom in on the lung and the alveoli, again, it's pretty much the same process, but just to sort of show why this might matter in COVID or in the SARS-CoV-2 infection, again, accesses through the ACE2 receptor that downregulates the receptor, and again, you get less degradation of des-Arg bradykinin. You have a bradykinin activity that, again, if ACE is inhibited, you're going to hit the B2 receptor, and all of that, of course, leads to leak. It leads to vascular leak within the lung, within the alveoli. And once again, not happening in a vacuum, you get upregulation of particularly the B1 receptor with all of the other inflammatory responses, IL-1 and so forth, that come along with a systemic viral infection. All right, last busy diagram, I promise. This is just to show you how this all fits together. And of course, it's very complex, and I don't think that we have a full or good understanding of it. But I've covered sort of the ACE story with the bradykinin receptors. The other things I would mention, and this is pretty interesting in terms of looking at some of the therapies in the future, the contact system has, at least in mouse models of COVID-19, you do get contact system activation by the virus itself, at least in the murine models. And so this is part of the inflammatory response that now is hypothesized to potentially play a role in some of the lung inflammation and injury. And again, you get complement activation, you get, of course, cellular activation, releasing cytokines. And so you get this whole inflammatory response, but there has been considerable interest in the bradykinin system in terms of actually the vascular permeability that may lead to the severe lung complications. On this diagram, also part of the reason I showed it is now we've plugged in some of these medications or that are directed at the contact system. So, of course, Calichron inhibitors, either short-acting or long-acting, and ecallantide or lanadelumab, Icativan, which blocks the B2 receptor, and then C1 inhibitor concentrate, which of course has multiple inhibitory properties, but includes Calichron, plasminogen, factor 12, and so forth. And so this is, of course, the basis for people suggesting maybe we should look at these in these people that are having complications. If we can shut down or regulate the contact system, perhaps that will confer some clinical benefit. All right, and this is my pause point. All of that, just so you know, is what I call the art of hand waving. It's very interesting science, and it actually is based on a number of studies, you know, again, mostly animal studies and so forth. But this was not real world data. This was the supercomputer followed by lots of people looking in the literature and putting together the pieces. So the question, of course, for us, particularly as clinicians, does any of this matter? My favorite mentor, my best mentor, Andy Saxon, who some of you may know at UCLA, used to tell me, "So what, Mark? You told me all that. So what?" And so let me show you now the so what of this. Does it matter when we're sitting with patients in the hospital or in the clinic? So we at our center, with these publications and the so-called hand waving, but really the hypothesis of the contact system's role in COVID, we became very concerned, and we started talking, of course, to our own patients, but taking calls from Europe, where there, of course, Italy and Germany and other countries being hit very hard by COVID. I'm talking to our own centers, our colleagues at other centers in the U.S. And interestingly, we was only anecdotal at the time, but we weren't seeing a lot of infections because you have a rare condition, and of course, it was a terrible pandemic, but a minority of the population actually getting infected. So we weren't seeing that combination very often. And when we were hearing, yes, people were getting some HAE attacks, as we often see with infections, but we weren't seeing people in the hospital, in the ICU. We weren't seeing the severe complications that one might have hypothesized if the contact system were playing a major role. But we needed data, and we continue to need data. I'm going to show you what we know so far. But there's additional data forthcoming, and I know of a number of projects in the works. Here's what we know. This has been published in the last few months. We have a cohort from Brazil, and we have a cohort from France, two different publications. Each of them, interestingly, has 13 patients. So we're talking about a small data set, but very similar results in both. In those data sets, 31 to 38% of patients with HAE reported attacks, episodes of angioedema during their COVID infection. That's, again, 4 out of 13 and 5 out of 13. Those attacks were treated with their usual therapy, their on-demand medicine, which worked as effectively as it did before COVID, and there was not any reported evidence of increased severity of those angioedema attacks. In these small cohorts, 8 to 15%, so that's one patient in one cohort and two patients in the other cohort, were hospitalized for COVID due to pulmonary complications. And interestingly, 2 of those 3 patients were over the age of 65. One was a bit over 65 and one, I believe, was 80. So we know age is an established risk factor for complications. All of the patients recovered. There were no fatalities. Everyone left the hospital. So what we see, again, albeit a very small data set, but one that's been fairly rigorously vetted, is that the effects in HAE of COVID are generally consistent with what we're seeing in the general population, with the exception, of course, of the HAE attacks, which are not that unusual during the course of an infection. We know that's a trigger. We've been involved with the US HAEA, so the Patient Association in the US, to conduct a survey of patients. And I can only tell you so much because this is in review right now. We hope to have it published shortly. But this will be, if it gets published, a large data set of 690 plus C1 inhibitor deficiency patients, and we looked at family controls. And the upshot of what we saw in broad strokes is no difference in the incidence of the infection between those with C1 inhibitor deficiency and their related controls. We did not see an increase in severity or complications with COVID-19 in the HAE group. We did see an increased risk of reported symptomatic infection in patients with HAE that were not on any treatment. And again, we would hope in this day and age in the US that most patients have treatment, but we did have a small group that reported no access to any HAE medicine or not taking any medicine. And interestingly, we saw a little bit of a signal in terms of symptomatic infection in that group of untreated patients. We also saw a reduction in the reported infection rate with the use of certain medicines. And I'm not going to speculate today about what that might be. It was sort of an interesting finding, and we're still working through what that might mean in terms of the underlying mechanism. But we did find a couple of these interesting sort of data points with regard to untreated patients and potentially some reduction in the reported incidence with certain types of medicine. So stay tuned if you're interested. I hope that'll be a paper that we can read and discuss before too long. Now, the other thing that's been looked at during the pandemic, which again may not be that surprising, but it was an interesting opportunity to look at this role of stress in hereditary angioedema. We know that this is a reported trigger or factor in many patients, perhaps not in every patient, but this concept of psychological or mental stress as a trigger for attacks. And, Alan Kaplan and others have done some really interesting work looking at what I would call the mind-body connection, but there actually is a mechanism potentially that the sympathetic nervous system releases mediators that, in fact, based on what Alan's shown with cytokines, do have the potential to activate the contact system. So this may not simply be psychology. There probably, of course, is a real mechanism underlying pathophysiology for this idea of mental stress causing contact system activation and angioedema attacks in these patients. At any rate, this was an interesting study that just was published out of Turkey, a large HAE center in Turkey, and they actually looked at stress and attack rate during the pandemic. So you can see these are patients with HAE. I think there's about 140, give or take here, that they actually filled out questionnaires based on their standardized psychological assessment, but also kept track of their attack frequency and severity. And they followed these for 2 months during the quarantine period in Turkey. So that was roughly from March to May. And then a similar time period, what they recall the return to normal period. And I looked at the paper because this is sort of May through August of 2020, which again was not a great time globally. But this was a time that locally in Turkey, they sort of relaxed a lot of their quarantines and people were at least at some level moving back into their usual social activities with some restrictions. So they compared these two periods, again, looking at these standardized scores, psychology measures or tools, attacks, and then they looked at sort of the correlation of these outcomes. What they saw may not surprise you, but I think it's a very interesting demonstration of what we see with patients with HAE. The number of attacks was substantially increased compared to baseline, and it actually came down. These look pretty similar, but they are statistically different. So higher during the quarantine period, lower as they returned back to normal life at some level. The severity was unchanged when they looked at that. And again, not surprisingly, stress levels, whether you look at anxiety, stress, depression, were significantly higher during the quarantine period and significantly lower when people were returning back to their normal activities. That was also true for their fear of COVID-19 based on a standardized score. And, this is sort of, you would say, yeah, well, that's what I would expect, but it sort of was a nice opportunity to prove it. The fact that these stress, anxiety, and depression scores had a strong correlation with both the number and the severity of attacks. So interestingly, even though the severity didn't change that much, if you mapped out individually people's stress and anxiety, it did map or it did correlate with their severity of their attacks. And that was true actually for the quarantine and the return to normal period. So it's just a nice opportunity during the pandemic, a very stressful time for everyone, but in this cohort of patients showing that, yes, there is a correlation between stress, anxiety, depression, and the attack rate and severity, and they were able to demonstrate that tracked during the pandemic in this Turkish center. All right, so I talked a little bit about the contact system. I talked about the medications that target the contact system. What do we actually know about these medicines and their utility in treating COVID-19? And I really like this quote. It's sort of a funny picture, but Thomas Huxley was English, actually a biologist and anthropologist, and he did a lot of comparative anatomy. He was at one point called the Darwin's bulldog because he did a lot of the anatomical studies that sort of supported the evolution. And so anyway, he was an interesting fellow, but I like this. I like this saying. I think it's very true in what we do in medicine. So here's what we know about the medications. First off, the studies are very small. So this is the contrast between theoretical hypotheses and actual data that we have in real life. Recombinant C1 inhibitor, and so we recall C1 inhibitor has a number of inhibitory properties in the contact system. We have a total of published at least a total of 5 patients. These were, just a reminder, these were not HAE patients. These are people with presumably normal C1 inhibitor level and function, but they were hospitalized for COVID with O2 sats of less than 93% on room air. And they had to have evidence of progressive disease after 24 hours. They were given the recombinant C1 inhibitor. These are fairly high doses. So you can see typically in HAE, we give this 4,200 unit dose as a max. They gave a sort of a double dose up front and then gave 3 additional doses in 12-hour intervals. So basically getting steady doses of this over a couple of days. And again, small data sets, but 53 to 85 years of age. They had COVID-19 pneumonia confirmed by CT scan and were treated pretty early in their course, a median of 1 day, though there was one patient that was treated about a week after their admission. And then this was not a randomized study, so they pulled these matched controls that just got standard therapy. And I won't belabor this. You can see there's a lot of noise, a lot of different treatments that were used for standard of care at this point in time. But the upshot is that they did not see any statistical difference. Of course, again, it's 5 versus 15 patients, so you don't have much power. They did see a trend towards less intubation or death. So numerically, the numbers look better, but I think it's fair to say we don't know. And so there is a larger study ongoing in Europe looking at this. Of course, we hope that as the pandemic slows, perhaps this enrollment will not be particularly brisk, but bears worth looking at, but I don't think we can say anything about this data set. Icativan, so B2 receptor antagonist. Similarly, small study, so 10 patients with COVID, again, not C1 inhibitor deficient, in the hospital, low O2 sats less than 90% on supplemental oxygen. They had abnormal chest CTs, and they were given 3 doses of Icativan every 6 hours. They also not a randomized study, but they did do matched controls that received standard of care with no Icativan. And what they showed is that 8 of the 9 patients treated with Icativan had a reduction in their oxygen requirements over a 24-hour observation period. So 89% in the treated group, only 17% in the standard of care group. And so if you sort of map this out graphically, on the right are the controls, on the left are the patients, and you can pretty clearly see this drop in oxygen requirements for the vast majority of people that got Icativan, and really kind of all over the place with no clear pattern for those that were on standard of care. So again, very small study, and you're looking at an outcome of oxygen requirements, so not mortality or hospital stay, but perhaps the suggestion that there was some effect on this blockage of the B2 receptor on respiratory symptoms or status. And lastly, this is the only randomized study that we have. This was just published a couple months back. An open label but randomized study of, again, severe COVID patients that were symptomatic and hospitalized for less than 12 days. You can see they had a number of eligibility requirements, which really pared down their group of patients to these 30 that were randomized, and 10 to each group. You've got a group that got standard of care, a group that got Icativan, and that was every 8 hours for 4 days. And then a group that got plasma-derived C1 inhibitor, in this instance, the sort of standard weight-based dosing on day 1 and day 4. And so you can see there was a death in the standard of care, there was a death in the C1 inhibitor group. But overall, if you look at what they designed as the primary outcomes, so either time from admission to discharge, so total hospital time, or time in the ICU, there was no statistical difference between these treatments. And so, again, with these small data sets, you have very little power to look at differences, but not any clear, even numerically, it doesn't look like there's a trend even in the right direction for these contact system targeted medications. They had a number of other outcomes or endpoints, and so you can sort of look at this as data dredging, sort of looking for some silver lining. But they did show that the CT scores improved by blinded reading of the radiologist for Icativan and C1 inhibitor. Again, to the eyeball, these don't really look that different across the board, but they were statistically different for those two treatment arms. So again, perhaps a weak suggestion of some benefit, but really not dramatic effects. And so I think the story here, of course, is that while there may be some influence of the contact system and the COVID pulmonary complications, I think that's not the whole story as we might expect, and it may be a bit much to expect that these therapies are going to be a magic bullet for these very sick patients. So as I mentioned, studies are ongoing. We'll see what comes out of that. But so far, the preliminary data sort of, I don't think we can say much about any clear benefit. So here's a summary of that. I think for HAE patients, so far the data has been reassuring. And as I mentioned, I'm aware of a couple of other efforts and projects where we probably will get data in the coming months that'll be published. So they hopefully will have larger data sets. We can sort of see if that bears out. But so far, so good, I think, in terms of HAE patients having a severe risk for COVID-associated complications, with the caveat that most of these patients are on treatment, either have on-demand treatment to use when they get attacks, or in some cases are on preventative treatment. So, that's what we want for our patients. We don't have a lot of data in the untreated population. And then, as I showed you and just mentioned, for these targeted medicines, Calichron, Boridokinin targeted drugs, very small studies, but I don't think we can sort of point to any clear evidence of benefit at this point in these hospitalized COVID patients. All right, for the last 5 to 10 minutes, let me shift gears for a moment and talk about diagnostics in this area of angioedema. And of course, our interest in this is maybe helpful, in things like COVID, where there's possibly a role of the contact system. But for us in our everyday lives, professional lives, it's really, we see these patients in clinic. And how do we know if they have a mast cell problem or a bradykinin problem, other than that history and C1 inhibitor deficiency testing? Most of what we do is trial and error, sort of trying treatments. And we'd like to get the right treatment to the right patients up front so that we don't put them through the burden of trial and error and all the suffering and recurrent episodes that occur if we get it wrong. So we're looking for biomarkers in the angioedema space. This is a nice paper if you want to read about biomarkers, and I've had increasing interest in that, seeing all these patients where we don't know what's causing their angioedema. This is a nice paper by Alan Kaplan and Cohn Moss, really just outlining what we know about biomarkers. We'd like them to give us either indicate the mechanism that will give us a treatment plan or treatment options. It could predict severity. We'd like it to be accessible, reliable, in an easily obtained sample like blood or saliva. And we need a reproducible assay that will sort of consistently give us an accurate result. And this, as I've mentioned, is for us in allergy is most applicable to this group of so-called HAE normal C1 inhibitor patients, where these usual labs for HAE looking at C1 inhibitor level and function don't help us with that group because they are in fact normal. So the diagnostic testing has really gone down 2 different pathways. The genetic markers, and we know that gene panels and so forth are slowly but surely making their way into really all fields of medicine. So there are these genes that I mentioned earlier that some of which are available commercially and some which are not, but we can look at that. Unfortunately, this has not given us the answer for a large number of patients, and so there's been a lot of interest looking at biochemical markers, and there's a laundry list, but things that people have been looking at around the world, either the specific function of C1 inhibitor. Just a reminder, when we send a C1 inhibitor functional test, we're actually looking at its inhibition of complement component 1, which, as you recall, has nothing to do with why HAE patients have angioedema. It's the factor 12 and Calichron inhibition. So there are people looking at ways to measure that function with our C1 inhibitor testing, which is much more relevant clinically. The threshold Calichron activation, we have a lot of experience with that at our center. I'll show you very briefly some data on that. And then looking at other proteins that would signify bradykinin excess production, or even kinins themselves. And I'll finish with showing you a little bit about bradykinin measurements, which is kind of exciting because that's been a dead end for quite some time due to technical difficulties. This is a new diagram, a recent diagram of HAE, and specifically I showed this to show you the HAE normal C1 inhibitor portion on the right. These are 5, and there's now a 6th gene that's been published, but these are genes associated with HAE normal C1 inhibitor in some families around the world. We know that that's a condition that most often affects females and has a few different clinical features, much more affecting the tongue and the oropharynx for some of these types, and much more affected by estrogen, but sometimes hard to tell just by looking at a patient which one of these we might suspect. And so, as I mentioned, genetic testing is sort of making its way into this field of HAE normal C1 inhibitor. There is a commercial gene panel now that's available. It includes factor 12, plasminogen, and angiopoietin, these 3 kind of on the left. These others over here are not yet available commercially unless you design a custom exome, which is still a bit costly on a commercial basis. But there are some research centers, including our own, that are sequencing for these in patients where we're suspicious of HAE normal. But there's a group that still has this unknown cause, meaning they don't have any of these identified mutations to date. And because of that, there's been this interest in biomarkers, and these are some of the papers published over the last 5 or 6 years reporting some of this data. I want to share with you just a couple of quick things. This is SGP120, the paper down here at the bottom, and Mike Frank, who we lost a couple of years ago and was a big loss for the field of hereditary angioedema. He taught me a lot of what I know about HAE. But one of Mike's last projects during his career was to look at this protein, which it turns out is also cleaved by Calichron. So we know Calichron is important for producing bradykinin, but there are challenges to measuring that activity specifically for bradykinin production. SGP120 also is cleaved by Calichron activity, and Mike was able to show that in these patients that either have factor 12 mutations, plasminogen mutations, or an unknown mutation, the HAE unknown, that most of those patients, if you incubated their serum at higher temperatures, they cleaved this protein. And so that demonstrated this excessive Calichron activity compared to the normal controls. And so he was able to show that this was fairly sensitive and highly specific for identifying these patients. Not all of them had this finding, but most of them did. And this story sort of folds into what we've seen at our center with Calichron activity. This is a so-called threshold Calichron activity assay where you take the patient's plasma and you actually stimulate it with dextran sulfate, which we know is a strong activator of the contact system. The red line here, you can see if you put in enough dextran sulfate, you will activate the system in everybody, including normal, healthy people and people that have urticaria and angioedema. But what we were able to determine is that there is a level, a dose threshold at which you can separate people that have hereditary angioedema. So here's C1 inhibitor deficiency, factor 12, some of the unknown patients. You can separate those out from people that are either normal and healthy or have histamine-mediated angioedema in that blue line, that blue dose there. And so we've shown in our cohort of patients that this has sensitivity and specificity of 80% or greater. So we're working to validate that. And again, there are other groups doing other assays that I think could be very, very helpful for us in the clinic if we can bring them through the validation studies. And this just shows you all of the activity going on in various labs, trying to find a biomarker. So there's the genetics and then there's the biochemical markers that would be really helpful to have at our disposal when we're seeing a patient for recurrent angioedema symptoms. And lastly, I'll mention one of the silver linings. It's hard to find positives in the catastrophe that was this COVID pandemic. But if we look for small positive things, at least in my world, this is one that's come out of it. There's been this renewed system in looking at the Kinin Calichron system. And this is a group, this was just published this month, looking at measuring Boridokinin and active kinins. This is proven to be technically extremely difficult, which is why we don't have a Boridokinin test in our clinics these days, because it's so labile and difficult to measure the active kinins. So this group has used some advanced technology, mass spec and liquid chromatography in tandem, and has now shown that they can reliably measure not only Boridokinin, but Des-Arge Boridokinin, which, as I mentioned, is also important in terms of vascular permeability. And again, I won't pretend to know how to read this, but you can see the limits of their sensitivity. And then using this liquid chromatography with tandem mass spec, they can actually measure, here's Boridokinin and Des-Arge Boridokinin in these human samples. And so this may open up another pathway to us in the clinic, having ability to say, okay, if you're swelling, let's measure a Boridokinin level, because that may be helpful in us determining what treatments are going to make sense for a given patient. So that's kind of exciting to see that revisited. So I'll just finish with this. HAE in the contact system has become more and more complex, but our understanding has become better. All focused around this mediator of Boridokinin. But we've got these various mutations, which I've highlighted with the red arrows. But we've also got an opportunity to measure some of these other mediators as a way to sort of shed some light on who's affected by these conditions, given that we now have targeted treatments at our disposal that in the right setting may be very helpful for treating or preventing these sorts of complications, whether we're talking about HAE or maybe in other conditions, and COVID has really brought that to light. And so at the end of the day, being able to use some of these tools eventually to pick these folks out of the universe of angioedema, we know, of course, that allergy or mast cell mediated swelling is always going to be more common, but it'd be nice to be able to pick these folks out and give them the targeted treatment they require. So this is just my summary slide. I talked about the angioedema symptoms associated with COVID-19 that come in these two flavors, both mast cell mediated and non-histaminergic. We talked about the hypothesized role of the contact system in COVID-19 and the idea that this may be a factor for patients with HAE, but we generally so far have reassuring data that we're not seeing a high complication rate to date. The hypothesis of some of these targeted drugs for a role in treating COVID, but really the small studies that have been done have shown marginal, if any, benefits in the real world studies, but more data may be forthcoming. And then I talked a little bit about diagnostics and how the advances in those moving forward might be very useful to us in treating our patients. And so with that, I'll close. I'll say thank you. And I understand that you may need this word of the day on the slide to get your CME credit. So thanks again for your attention, and I'm happy to take any questions we might have in the last couple of minutes.
Well, Marc, thank you. As I promised, we saved the best for last. Really a brilliant presentation. If you keep giving presentations that good, we'll have to invite you every year. So
I'd love to come see you guys in person. That would be great. Thanks.
We would like to have you. I really hope by September that that's a reality for all of us. We have about still 45 or so people listening, so I welcome any questions. I guess one interesting thing to me is this brilliant supercomputer crushing 17,000 specimens and coming up with a potential explanation for interfacing these two, but in the real world didn't really seem to hold up. Anything that supported the computer analysis of the data. That's not really a question, sort of a statement, but you might comment.
Yeah, I agree. I mean, I think obviously those, they use these fancy neural networks and things that are beyond me, but one would like to think that that is valuable, and I'm sure it is at some level. I think, my view of it, and I'm not an expert in, COVID per se, but having seen some of those patients, as we probably all have, it's so complex. Those patients are so sick, and it's sort of like sepsis, right? Where it's the dark joke that, you know, sepsis is the condition where all medications go to die. I just think it's so complicated that I think, you know, targeting one system, maybe if you do it very potently, is just not sufficient. Perhaps not sufficient to overcome the illness or the complications. But, you know, there is some very small signals in some of these very small studies, and maybe a larger study will prove that there is value. But it's a pretty interesting approach that we'll probably see more of in the future.
This is Vinod Doraiswamy, one of the local practicing allergists. Thank you so much for, you know, an awesome talk. That, you know, learn everything every single time. So when you talk, I just had a clarification. I think you alluded to, you know, HAE patients on medications or without medications. Were you alluding again as, you know, prophylactic medications, or were they like even, you know, treatment medications? Were there a difference between the two from that perspective?
Yeah, so we looked at that data very closely, and again, since it's not published, I don't want to say too much, but we did not see, what we saw was actually a lower prevalence of symptomatic COVID in people on specific treatments, and it was the prophylactic treatments largely. And I'll just tell you, I mean, again, we'll see what the peer reviewers think of our data, but it was actually C1 inhibitor prophylaxis that seemed to have the best outcomes, or I should say the lowest reported symptomatic COVID. We did not see more severe courses really anywhere across the study. But the reason that's sort of interesting is because, you know, I pointed out the complement pathway, which C1 inhibitor is the one HAE treatment that sort of hits that pathway as well as the contact system. And so we were intrigued by that finding. Whether that will, you know, bear out to be important at the end of the day, I don't know. But that's the one sort of signal that we saw in the data, and so might suggest that there are differences between, you know, the mechanism and potentially the benefit of the different therapies we have for HAE as it relates to, again, reported COVID symptoms, for what that's worth.
Marc, I have a question. Is it unique to this virus to use the ACE2 receptor as a means of infection, or do other coronaviruses, previous coronavirus infections, what receptor do they use?
It's my understanding, and I could be wrong, so double check this, but I think this is common to coronaviruses. I don't think it's unique to necessarily the SARS-CoV-2. I think it's been described with some of the other, you know, SARS and MERS and some of the other coronaviruses that have been studied very carefully because of the severity of illness. So that's my understanding, but I'm not certain about that.
Marc, this is Frank Veron. Just curious if you've been asked to consult about acute angioedema after COVID vaccination.
Yes, I don't know about you guys, but we've been, you know, swamped with COVID adverse effects consults. I have to admit, it hasn't been as many as I might have thought. And so most of those, as you might expect, have been sort of immediate reactions, you know, within the first few hours, that there were sort of, I think, classic for mast cell mediated events. So we've obviously treated those, and then have recommended generally against repeating the same vaccine. I've seen a couple of patients, actually more with urticaria, that have had delayed responses where the hives showed up several days later, which I sort of, again, have attributed to the inflammatory or immune response that we expect to see with the vaccine and we see with other vaccines. So I haven't seen anything too, I guess, out of the ordinary. And interestingly, for what it's worth, we've, of course, talked to our HAE patients a lot, and they have really, with the exception of one individual who did seem to have an attack of HAE after the vaccine, really have not seen any issues with immunization triggering attacks in our patients. So we've been, encouraged by that as well, that while we're always careful, we haven't seen a signal in terms of the vaccine causing problems for the HAE patients. So that's kind of been my experience with the vaccine related to angioedema.
Great, thanks.
Any other questions before we end for today and end for our series until September? If not, thanks again, Marc. As I was serious, we'll certainly have you back again next year, hopefully in person. For everybody else still listening, this is again the last session. We'll start up again, I think September 21st. I've got to start putting together next year's schedule, and I could certainly use everybody's help. Take care.
Thanks, everyone. Have a nice summer.
All right. Bye-bye.
Bye-bye.